Uh, Dr. John Mandrola is a cardiac electrophysiologist and endurance athlete based out of Louisville, Kentucky. He's quite active on social media, and I think that I first encountered him in the blogosphere around 2009 or 2010 when he was writing about cardiology, medicine in general, cycling, his family, and how all of these things interface. These days, in addition to active practice and publishing in cardiology, he interprets the latest cardiology studies for trials and fibrillations with Medscape. What's always struck me about Dr. Mandrola is his sensible, person-centered thinking. He's always advocating for a compassionate approach to serious illness rather than targeting the lowest LDL or titrating drugs to target doses. And it turns out that that perspective has been heavily influenced by his wife, Dr. Stacy Mandrola, who's a palliative care physician. Recently, he wrote a piece about COVID-19 and our response to that. And Dr. Stacy Mandrola called Dr. John a balanced voice in a sea of conflict and hyperbole, which I think is an apt summation. So it's my pleasure today to welcome him, to share that perspective, and to open all of our eyes a little bit wider. Welcome, John.
Thank you. Thank you. I'm going to share my screen and we'll get started. Let's see. Okay. Can you see everything okay?
Yes.
Okay, great. So I'm, first of all, I want to say thank you to Therapeutics Initiative to have me. It's a real pleasure. I wish that I was in British Columbia, but of course we're now virtual. I was going to talk about 3 legacy prescriptions: aspirin and beta blocker and statins. And really, these are all new slides. I kind of made these from start. I come from Louisville, Kentucky, which is right here. I have no disclosures, no relationships. And my hospital is a kind of a humble little community hospital with a couple EP labs and all kinds of services. And my goal today is really not to make practice easier, but I hope to make it a little harder, because one of the things that I have in my bio is that the more you see, the harder medicine gets. And I added this slide because one of the pieces of feedback that I've got previously from TI is that Dr. Mandrola didn't really clear anything up with his talk. And so I really want to just kind of lean into that uncertainty. So we'll start by noting that, when we look at trials, the internal validity is the quality of the study and conduct, minimizing bias. And this is, of course, the first thing, but we'll focus mostly today on external validity, really the art of medicine. And we'll talk a lot about evidence, but of course, in Sackett's EBM, that it's really not all about evidence. There's clinical expertise and, of course, patient values and mixing it all together. And I'll start with a poll question. So this is a Slido thing, and I have it open. If you had moderate or greater cardiovascular risk, would you take a preventive aspirin? Yes or no? And so, Judy, I guess we pause for a second here. And Slido is showing that, well, this is perfect, actually. 54% yes, 46% no. So that's great. I hope to change your mind. I hope to change minds here. I'll start with a case. This is a case that actually got me interested in this. An 84-year-old female had PCI 10 years ago for real STEMI. Her ejection fraction is normal, and she was started on guideline-directed medical therapy. And she remained on this medical therapy for many years. Then she, like many older adults, developed diabetes, urinary retention, dyspepsia, and took other medications. She presented with a syncope and a fall and a hip fracture, then developed a pneumonia and had a tremendously long course and a rehabilitation. During her hospitalization, we found that she had multiple 8 to 10 second pauses that were exacerbated by the beta blocker. So guideline-directed medical therapy actually clearly caused harm in this woman many years after it was started. And so let's start with the RCT level evidence for beta blockers. You know, there's coronary disease indications, STEMI, non-STEMI, stable coronary disease, and of course, heart failure. And I'll address first the coronary disease. Take a look here. These are 3 challenges on the external validity or generalizability of beta blocker use in coronary disease. I'll blow up these studies here and look at the 3 factors: the years that these studies were done, the follow-up, which is short, and the average age of patients, which is all young patients. And so my point for beta blocker evidence in coronary disease syndromes is that they occurred in an era before early revascularization. They had very short-term follow-up, and they recruited younger patients. Now, in 2019, the Duke group performed a registry study looking at 7,000 patients after MI, and this was observational. So 72% of patients remained on beta blocker, 28% were not. Look at the ages of these patients, 75 years, and they found that beta blocker use beyond 3 years after MI was not associated with improved outcomes. So again, observational, but no benefit. This was a study from just 2 months ago from the ESC, 27,000 patients with the first MI over 2017. And again, similar, 79% received beta blockers, 21% did not. And look at what happens. Recurrent MI, CV death, the Kaplan-Meier curves are identical. No difference in outcomes, whether they're on beta blocker or not. So these findings, of course, challenge the current clinical guideline practice recommendations. And here's a meta-analysis, which kind of lays it out nicely. This is a meta-analysis, RCTs of beta blocker from the pre-reperfusion era, post-reperfusion era, 60 trials, primary endpoints or hard outcomes. And again, looking at pre-reperfusion, the hazard ratio is 14% reduction, statistically significant. Post-reperfusion, almost no difference in beta blocker use. Now, the good news about this is that there's multiple ongoing trials. This is a Norwegian trial, 10,000 patients, and they're actually going to randomize patients to beta blocker or no beta blocker after myocardial infarction. And here are 3 European trials that are going to look at beta blocker withdrawal in patients. And I think we'll really, in a few years, I think this is really going to change, and we'll probably not be using beta blockers routinely post-MI after reperfusion. Now, what about beta blockers in heart failure? I get in arguments about this all the time on the wards. This is the MERIT heart failure trial. I'll go, this is one of the landmark trials, thousands of patients, primary endpoint death, young patients. And again, this trial was stopped early for benefit, a huge absolute risk reduction in death. So the beta blocker trials for heart failure look like this. And I made this table, carvedilol, metoprolol XL, bisoprolol, 1990s era trials with huge absolute risk reductions. But the thing of it is these are 1-year trials. The young patients, 58 to 63 years old, and they excluded patients previously on beta blockers or who had indications for beta blockers already. And so I always like to emphasize that these studies were done in stable young outpatients with mostly sinus rhythm. So in another case, an 82-year-old woman with AFib of recent onset with poorly controlled rate, and she had dyspnea, aroused congestion on chest x-ray, so heart failure. Her echocardiogram, of course, during AFib was 30%, and comorbid conditions, kidney disease and arthritis and limited mobility. And I wanted to use short-acting beta blockers to control her rate, but the heart failure docs say, no, you have to use metoprolol succinate. So I asked the question, do the heart failure trials apply? And what about atrial fib and heart failure? This is a fascinating meta-analysis. I was actually there when it was presented at a European Society meeting. This is from a group in London, individual patient level meta-analysis of 10 trials of beta blocker versus placebo and heart failure, 17,000 patients. And 76% of the patients were in sinus rhythm, 17% in AFib. And look at the two curves. If you're in sinus rhythm, there's a significant benefit to being on beta blocker. In atrial fibrillation, no benefit. And when they broke this out, the three trials that I just showed you, the Merit, Copernicus, and Cebus, bisoprolol trials, a significant benefit to being, if you're in sinus rhythm, no significant benefit if you're in atrial fibrillation. And again, the thoughts on this are that the methods are strong and that when you have individual patient data, that allows for adjustments of covariates, which is good. Now, the authors were cautious. They said the data does not suggest worsening, but they do challenge the assumption that beta blockers improve prognosis in heart failure with AFib. Editorialists wondered, what are the plausible mechanisms? I mean, why would patients with AFib not benefit? Of course, they pointed out that when you dichotomize into sinus rhythm or AFib, that's problematic from a statistical standpoint. But still, this is really interesting data. And so I don't know the answer. I'll leave you with the more you see, the harder medicine gets. Now, aspirin. The poll question was for aspirin, but so let me just move on to the second part of the talk. And I'll start, really, the aspirin story changed in 2018 with the ARRIVE trial. One of the ARRIVE trial, 12,500 patients. These are moderate CV risk, aspirin versus placebo, hard endpoints. And look what happens. No difference in this primary outcome in ARRIVE. Double the risk of gastrointestinal bleeding. Second trial in 2018, ASCEND, 7.4 years of follow-up, similar 15,000 patients of diabetes now, no cardiovascular disease, hard endpoints. And again, 12% decrease in cardiovascular outcomes versus a 29% increase in bleeding. No effect on GI cancers. They also looked at that. Aspirin, similar study, almost 20,000 patients, aspirin versus placebo, again in 2018. Here looking at death, dementia, and persistent physical disability. Hazard ratio, no difference for cardiovascular outcomes, and a 38% increase in major hemorrhage. And the Aspirin trial also had a mortality arm in the healthy elderly. Here, they separated out and looked at the elderly with a primary endpoint of death. And look at this, a 14% increase in death that made statistical significance when you're looking at aspirin in the elderly. And so I put together a table. Look at the numbers of trial, number of patients, tens of thousands of patients. Moderate CV risk, diabetics, elderly, long duration trials. The cardiovascular, cardiovascular endpoints non-significant, and the elderly and risk increase, and either significant increases in bleeding. And so when I look at these, one more thing that I was involved with. This is a study that Matt Nudi at Penn State did, and I was involved with. We were looking at aspirin as baseline risk increases. And so we asked the question, is aspirin more efficacious for primary prevention as the baseline risk increases? And we used the event rate in the control arm of aspirin trials. And what we found is that in older trials of aspirin, you can see the benefit in CV reduction. Things are to the left of the left here. And in newer trials, there was not significant benefit, like ones I just showed you. Heterogeneity, 34%. We found that with bleeding, though, there was no heterogeneity, 0. And again, here, significant increase in GI bleeding. And when we looked at on the x-axis here is the event rate in the control arm of these trials, there was no significant difference, no significant relationship between the event rates in the control arm and rate reduction. So it doesn't seem to matter in primary prevention how high a risk there is. There doesn't seem to be a reduction with aspirin. And so my conclusion is that unless there's been a vascular event, stop the aspirin. Okay, so it's time for another poll question. I'm moving on to the third part of the talk. And so it seems the poll question is, do you buy lottery tickets? Yes or no? And so I'll just wait a second here and we'll see what the answers come. Very interesting. Very interesting. Okay. Canadians are different. 80%, 79% said no, and 21% said yes. And I hope to show you. One of the study that I'll show you one of the studies that really changed my view of statin therapy, and then we can talk about it. So for statins, this is the third part of the talk. I want to first start with one of the best essays I've ever read on statins by my friend Saurabh Jha. And he wrote on the healthcare blog, 2016, and I have the hyperlink here, and if the slides are up, please read this. It's one of the best pieces ever. And here are two quotes. Statins enjoy the metaphysical carapace, the immunity from falsification, which not even God enjoys. And here's another. Once you're taking statins, there is no way to disprove that any and every breath you draw is because of statins. And so anyways, just go look at that. It's absolutely beautiful. And so when I talk about statins, I'll have four aspects. The first aspect is comorbidities. And Richard Fries wrote in the 1980s that after you reach age 75, life expectancy is pretty flat. And so that's important for statin therapy. I'll also talk about statin efficacy and how some of the guidelines differ. We'll talk about how to balance harm and benefit. And then we'll talk about shared decisions and what people feel about taking a pill. So I'll start with two trials that really opened my eyes. And I'm embarrassed to say that I just discovered these relatively recently. And they highlight the importance of competing risks of death. And the first two are two large trials in heart failure with reduced ejection fraction, GC heart failure and corona. Almost 10,000 patients, heart failure with reduced ejection fraction with any cause, ischemic or non-ischemic, statin therapy, rosuvastatin, no difference. Rosuvastatin did not reduce hard cardiovascular endpoints in patients with heart failure. Very similar data in patients with end-stage kidney disease. Again, big, large, randomized trials, rosuvastatin and atorvastatin in patients on dialysis, no difference in hard endpoints. And again, I think this is because of competing risks of death. So I like to use these data to reduce pill burden in patients with comorbidities. Now, this may be controversial, and I know Rory Collins' stuff is controversial, but the statin efficacy, really, if you look at everything together, these drugs have been studied, 130,000 patients in RCTs, and consistently with all of these major vascular events, the risk reduction is about 24 to 25%. And this was confirmed in the HOPE trial, which is relatively contemporary intermediate risk patients, rosuvastatin versus placebo, nearly identical amount of relative risk reduction with statin therapy. And so this is a bit pedestrian. You all know this. If you have a low absolute risk and you multiply it 25%, then the absolute risk reduction is pretty modest. NNT is pretty high. But down here, if you have a high cardiovascular risk, then that's going to correspond to a much greater absolute risk reduction. Another study and group of studies that changed me a little bit is when I met with Brian Ferentz. And Brian Ferentz does a lot of Mendelian randomization. And what this is people born with gene polymorphisms that associate with low LDLs from birth. And so this is work that he's done, kind of a seminal study, a meta-analysis of patients with 9 polymorphisms, 300,000 people. And of course, he calls Mendelian randomizations nature's RCT. And the allele that gives you low LDL is the exposure, and it's from birth. And so here are the 9 polymorphisms. And again, per about 10 milligrams per deciliter of LDL, you get pretty consistent reduction in coronary heart disease risk. And if you look at significant LDL reductions, 1 millimole or 38 milligrams per deciliter, the risk reduction in genetic studies is almost 2 to 3-fold greater than you see in randomized controlled trials. And Brian Ferentz's point is that, okay, low LDLs are important, and the time of exposure is important too. Now, so what cardiovascular risk should statin be started? And again, here I think you have to consider harms and benefits. And so I just simplistically think of statin adverse effects in 2 ways. Observational studies, here retrospective cohort studies, statin users versus non-users. And you can see in the right here that there's about a 10 to 20% increase in musculoskeletal complaints when patients know they're on statins. But that differs than when you look at randomized controlled trials. Here's a review from the University of Connecticut people. And if you just look at, they did a systematic review of trials, and it's almost the same in the trials. Statin withdrawal, stop statins because of muscle symptoms, nearly identical. We do know that there's a very small risk of true myopathy, hemorrhagic stroke, and we all know about the slight increase in diabetes. I want to, the tension between observational RCTs make me think about nocebo effects. And I really think words can harm and words can heal. And my favorite, I want to consider, do statins really cause minor muscle symptoms? And I want to show you a couple slides on that. The ASCOT trial was a trial of blood pressure lowering, but it also had a lipid lowering arm, atorvastatin 10 versus placebo. And interestingly, this had an open label continuation after the study. And look what happens in the double-blind randomized portion. Muscle-related symptoms were not statistically different. But in the open label continuation, you can see that muscle-related symptoms increased and really did make statistical significance. And so I think there is a nocebo effect. And I want to show you my favorite nocebo study that I've showed before. This is actually an old slide. This is an Italian study of 96 patients who had newly diagnosed cardiovascular disease, and none of these patients had erectile dysfunction. And there were 3 groups, and all of them received atenolol. Group A were blinded. Group B was informed on the drug, but not its side effects. And Group C was informed on possible erectile dysfunction. And look what the brain can do. Here, as you can just see, if you knew about side effects or knew about erectile dysfunction, nearly 30% versus less than 5% developed it in the blinded arm. Okay, let's move on. What cardiovascular risk should statin be started? A couple modeling studies. This is a Swiss study looking at balancing benefits and harms. And what this group asked is, what is a 10-year risk in which there is a 60% probability of the benefits being greater than the harms? And they used a modeling technique from the National Cancer Institute, and that accounts for competing risks of non-cardiovascular death. And they combined meta-analysis and preference and selected observational studies. And so here, if you look on the left, they looked at the harm outcomes, the cardiovascular risk reduction, and plus the competing risks. And they found that, here's the ACC guideline 7.5, here's the USPSTF guidelines, but they found that to have a 60% probability of benefit, you have to have a much higher CV risk, especially in older patients. So that's provocative that, if you count these harms, and that's one of the criticisms of this, that is that they weren't, they were using observational studies to count the harms. Now here's some more on statin harms and patient preference. Here's another observational and modeling study on cost effectiveness and impact of different intervention target groups. So the old ATP criteria, the ACC criteria, and just treating everybody based on age. And here in the red bars is the number needed to treat, or in the blue bars, number needed to treat, and the total number treated. And you can see on the left part of the slide, the best bang for your buck is if you treat high-risk patients. You don't treat as many, and you have a lower NNT. If you just treat everybody, you're going to treat way more patients, and you're going to have a much higher NNT. And then this group then did a simulation, 1,000 simulations, and they varied statin toxicity and cost. And you really want to be in the bottom right here. That's a difference in quality adjusted life years and cost effective. Now, the top bars here look at different criteria and no pill disutility. But on the bottom, they used a pill disutility. And here you can see that if you do that, then quality adjusted life years can fall into the left part, and you can see that it's not always cost effective. So really pill disutility is important. And so the editorial from that was written by Rod Hayward, who's a public health doc at Michigan. And he said that what people appreciate less is the unknowables. The null can never be proved. And he wrote some provocative things. Could being on a statin for 25 years result in a small decline in cognitive function or an acceleration in decline in muscle health? And if so, if being on a daily statin had even a modest negative impact, then it would reverse the marginal benefits of routinely starting a statin at 40 years of age, and it would also be a public health disaster. Again, unknowable unknowns, very provocative. A couple more slides and I'm done. This is the Daryl Francis group in Imperial College, London. And they were interested in what actually is the pill disutility. And so they went into public transport and just asked people. And they used a medication aversion, and it was quantified as a lifespan gain required by each person to offset the inconvenience or disutility of taking an idolized pill. Idolized meaning it had none of the cost, inconvenience, perceived loss of autonomy, or adverse symptoms. So the perfect pill. And look what happened. Yes, a third of the people on the left here said, okay, that zero pill disutility, they would take it. They would take it for a very small gain. But most of the people had had disutility requiring a much longer increase in longevity. And 1 out of 10 people would require living longer than 120 months. But here's the problem. In statins, with the average lifespan gain is very small, less than 12 months. So for people with disutility more than 12 to 24 months, statins represent a net harm. Again, this is provocative to me. So one of their conclusions is that guidelines cannot assume that statins have zero disutility. And finally, the study that changed my mind about statins. This is really, really important. I show this to patients often. And my priors going into this was that, yes, the trials provide average effect size. And the absolute risk reduction for most preventive therapies like statins are modest. And the NNT gives you a sense that most people do not benefit. And if you multiply those things together, that the average lifespan gain is indeed modest. But what they looked at is the distribution of lifespan gains from a primary prevention. And so they went and they used UK mortality data to calculate a lifespan gain, assuming a 30% reduction, so close to about statins. The probability distribution of lifespan gain was the second thing they did. And then they asked people on the London transport how they would evaluate the potential benefit. And what they found is from the UK mortality data that from age 50, the lifespan gain from a statin ranges from 3 to 14 months. And you can see on the left bar here, men get more benefit. And as you start statin later and later, there's less benefit. Okay, that's well known. But this is the provocative part. Distribution of lifespan gains versus average lifespan gains. And so if you consider a 50-year-old male, typical, here's what they found. On the left, the average lifespan gain for this person is 7 months. But when they ran these simulations, 93% of patients gain no increase in lifespan, whereas 7% of patients gain a huge amount. And so that's extremely provocative, that it's sort of like a lottery effect. And the effective baseline risk is really that in low risk women, 97% gain nothing, but a small portion, 3% gain huge. High risk men, 89% gain nothing, but 1 in 10 will gain large. And the effect of starting statins or primary prevention later, 96% of older women gain nothing, 4% gain, well, a lot, but 70 months, and similar in higher risk men. And then for the part 3 of this study, they went out and they surveyed the public preference between certainty of an average lifespan gain and chance of a large lifespan gain. And they assume that it's equally desirable to gain a 50% chance of 2 extra years or 100% chance of 1 year. And look what happened. When they assessed these individuals, they found in the middle here, you can see that the certainty of 1 year gain versus a 10% chance of 10 years, which is the same, is very similar. But here, the gray bars indicate choices that are not as beneficial. So a certainty of 1 year versus a 2% chance of 10 years. If you choose this, you're actually getting less. Same thing over here. It's a little bit less. This little bit less of the gray bars when you get out a certainty of 1 year versus a 50% chance of 10 years. And the point is that at each probability, many people preferred the option that gave the lower mean life expectancy. And so how it's changed me is that larger average gains and a higher chance of big gains come from starting earlier. Most gain nothing, but a small fraction can gain big, like avoiding a big MI or stroke at a young age. The higher the risk, the more likely one is to be a big gainer, and that people do not always choose the option that's mathematically maximal. Instead, people can often prefer a small chance of a large gain versus the certainty of a small benefit. So what this makes me think of is really what we need to move towards is a shared understanding, like Richard Lehman talks about. And a shared understanding is really understanding, everybody understands the evidence. We understand how decisions can be made together, and we understand how patients can have different preferences. And so a shared understanding of medicine is really a fusion of these 3 things. And finally, before I close, I mean, I really think that it's a preference sensitive decision. And if patients know all of this, then some will choose and some will not choose. And I think that's just fine. And so with that, I'll conclude and hopefully have a good discussion. Thank you very much.
Hi, Erin, your camera's off.
So the first question, Dr. Mandrola, it seems all those studies were for metoprolol. What about studies in bisoprolol, which it seems most cardiologists like to use? Is this a class effect?
Yeah, that's interesting. Actually, it's interesting, first of all, that most people use bisoprolol there. I would say here it's metoprolol XL. The landmark heart failure trials were really 3: metoprolol XL, carvedilol, and bisoprolol. And the heart failure doctors would really, you know, they would say that it probably we should stick with those 3 drugs for heart failure. However, what's interesting is that in ACE inhibitors and ARBs, then it's more or less people allow different ACE inhibitors that were in the trial. For instance, losartan has no RCT level evidence in heart failure, but that's allowed. So I think it's very controversial about the class effect, and the answer is I don't know, but we allow different classes for ACE and ARB, and I'm not sure why we don't for beta blocker.
Okay, thank you, John. The next question I have for you is, do you think it is more worthwhile to stratify patients according to cardiovascular risk score, or could we simply use primary versus secondary prevention? When looking at the evidence for treatment decisions, it seems more useful to simply ask whether or not the patient has had a cardiac event.
Yeah, 2 thoughts. My first thought is that if a patient has had a cardiac event, like a true ischemic stroke from a true vascular stroke, not an embolic stroke from AFib, or a true MI, PCI. I really think that that sort of can be a quasi-binary thing, and I think that would make them likely benefit more. It still doesn't answer the question of do they continue to benefit greater than 5 to 10 years out. But certainly in the first 5 years, I think if they've had a cardiac event, the answer is preventive therapy seems to be an easy way, yes. But cardiac events these days are that there's a gray area. Is a TIA count? Does a PCI for stable coronary artery disease count? What about if you get a coronary artery calcium score and you have a high calcium score? That's the gray area. Same with CCTA. So I think that I think that it's just that there is gray area there. I also want to say that the cardiovascular risk score is pretty easy to calculate just with a laptop and with a computer in the exam room, and I do it often, and it's kind of an eye opener for patients, especially when you then calculate it what it would be with the statin reduction. So I use it.
Okay, John, a follow-up question to that. Have you encountered patients that have very, very high cardiovascular risk by any scoring tool and have opted not to do anything?
Why, sure. Yes, yeah. Of course. And it's the same with anticoagulation and atrial fibrillation. There are some patients who have super high risk and choose not to do it. And I of course, I'm bothered by it, but what I try and ask myself, I sort of talk to myself, I say, John, are you sure that you've communicated everything properly to this patient? And if I have, then I feel okay about it. And one of the things that I feel about risk is that it's also important to that last study that I showed from Daryl Francis's group really got my attention, is that it's not just about the average risk reduction, it's also about the asymmetry of risk reduction. So if you take AFib, my area that I'm constantly talking with patients about, yes, the risk reduction with an anticoagulant might be 1% per year, but if you had a stroke, it's a catastrophic accident. And if I want patients to be able to understand not just the absolute risk reduction, but also the asymmetry of what happens if you're in that 1%. And, strokes are so devastating. We wouldn't get on planes if it had a 1% risk of crashing. So if patients are comfortable with that, then I'm comfortable.
Okay, thank you, John. The next question, and they're coming in fast and furious. Which model of CVD risk was used in the study? I'm not sure which study they're referring to, but they've also commented, I've noticed that the Framingham score is over-inclusive. For example, composite outcome includes claudication along with death, and have stopped using ASCVD seems at least more patient-oriented. Do you have any comments on that?
Yeah, I don't use the Framingham score, but Aaron, I don't want to sound unacademic, but I don't know that it matters that much. I think the scores kind of get you in I'm more interested in what they're telling patients in general rather than in specific. I'm more interested in the ballpark risk. And so, yeah.
Okay, and isn't it true that the risk scores, if they identify a percentage risk, it's plus or minus a few percentage points anyway? So
yeah, absolutely. And again, going back to an area that I'm super familiar with, the CHADS VAS score, everybody hangs their hat on the point estimate of what it is, but I could show you a study that looks at different cohorts, and CHADS VAS of 2 or 3. A 2 might range from 0.5% to 5% annual risk. So, I mean, it's just a ballpark for me.
Got it. Thanks, John. Okay, what about a 9-year-old with proven CAD, perhaps a stent within the past 5 years? Do we keep them on statins indefinitely if they are active and doing well otherwise?
That's it's a tough question because, you know, my wife, Stacy, thinks that old people should eat food, not pills. And, but, you know, a 90-year-old who's running around who is doing well and the statin's not causing her too much problems, I would probably not push. I would probably not push deep prescribing there unless there was a reason to. But I wouldn't be, certainly, you know, I wouldn't be opposed to it. But you know, that's a tough question. I think the easier question is I see 85, 90-year-olds on statins who are, you know, doing terribly, and it's just such a great opportunity to deprescribe, I think, in many cases.
John, can I ask a follow-up question? So if a patient is showing some reluctance to stay on the statin, but they're undecided to stop or keep going, have you ever said, why don't you try stopping it for a while and then restarting?
Of course.
Okay.
It's a great idea. Yeah.
And the concerns about what if something bad happens in the interim when they've stopped, is that ever, like, how do you answer that question?
Yeah, that gets back to the God and statins piece that Surab wrote, because, you know, you just don't know. You just don't know. I do think that, I don't know how it is in BC, but here, you know, we get looked at pretty carefully about whether our patients are on statins and ACE inhibitors and this and that. And so I would be careful probably in the chart about saying that the patient didn't want to take it and document it. And yeah.
Okay, great. This isn't one of the top questions, but someone just asked, what is pill disutility? Because that might clear up a few issues for a bunch of people.
Yeah, so pill disutility is, I'm sorry, I shouldn't have gone so fast through that. Pill disutility is how much time that you would need to have your life extended to take a pill for the rest of your life, and really an idealized pill that doesn't have any conveniences. So some people in that study felt like they would only have to have a couple extra months and they would take a pill for the rest of their life. But most people would require that this pill extend their life by, you know, 1 to 5 years. And, you know, a small group of patients, 1 in 10, felt like they would have to have more than 10 years to take a pill their whole life. So it's really a person's feeling about taking a daily pill and how much time they require to have their life extended.
Okay, thank you for the clarification. Here's a question that I'm interested in as well. Is there a role to use statins to reach an LDL target, seeing that most patients gain very little in terms of lifespan?
Yeah, so the target question is going to be debated by people far more expert than me. But in my simple mind, I really think that statins are cardiovascular event reducing drugs. They're designed to reduce cardiac events, and I just try and use the drugs that were in the trials. I keep it simple with atorvastatin or rosuvastatin and put them on either a moderate or high intensity drug. And if it were up to me, I probably wouldn't do many cholesterol tests. So that's how I think about it. That's controversial, though. There are other people who would argue that the PCSK9 data, the ezetimibe data, would suggest that the lower is better. So I think that's an area of uncertainty.
Okay. By the way, if your mind is simple, then I don't know.
My mind is totally simple.
Then I'm a clown. So on to the next question. Are you still supposed to use ASA in a diabetic patient if they have peripheral arterial disease? For example, is that considered a vascular event?
I think that I guess it depends. You know, if someone's had a stent or peripheral vascular surgery, that's surely an event. And those surgeons, the vascular surgeons, my interventional people, would for sure say yes. If you have a vascular disease that's just noted on a Doppler, that's a gray area. I would have to go into those entry criteria and look at that. But certainly if you've had, had an event, and I would consider that a secondary prevention. But Aaron, I am struck by our meta-regression looking at cardiovascular risk and looking at any of those trials, diabetics, elderly. These were fairly high risk people, and the risk reduction was pretty modest or not significant. And again, I think, just to expand on that, I think that older trials that were done longer time ago, there's been changes now, right? So there's been temporal changes. There's less smoking. There's less trans fat in the food, and so the underlying risk is probably lower. And it kind of, I think it explains why the benefit is more modest from the aspirin now. And really, I'm also struck by the significant increase, the 20 to 40% increase in GI bleeding that's consistent across the years. That's underappreciated, I think.
It was interesting to see that slide where the heterogeneity in the bleeding outcome was not
like
present
zero
at all. Yeah.
Yeah.
So,
yeah.
Fascinating. If you want to have a sip of coffee or a glass sip of
I'm
water.
okay.
Okay.
The aspirin data, where it also comes into my field, is that there's still residual use of aspirin in atrial fibrillation, which drives me bananas, because there's no data that it prevents stroke and atrial fibrillation. And some of the new comparisons between the DOACs, for instance, the Averroes study found that apixaban at normal doses really had a very similar bleeding profile to baby aspirin. And so I'm impressed by the bleeding risk from aspirin.
Thank you. A rather funny question. Yes or no answer only. Do you buy lottery tickets?
No.
Excellent. Moving on. Dr. Mandrola, do you think RCT findings are representative of the true degree of myopathy from statins? Don't the lead-in periods and exclusions for intolerance of statins, etc., in the studies reduce the apparent effect that you would see in patients?
I do. I think that it probably reduces it. I think it probably reduces it modestly, and I think that's a really good point. Is that the run-in periods for the statin trials is really important. We still, one of the things that I know Rita Redberg talks a lot about is the CTT people have not really released that open data, and I really wonder whether the true myopathy risk is a little higher than what it is, although it's pretty small and it probably is only modestly increased. But I think that's a really good point.
Okay, thank you. Have you ever encountered a pharmacist being asked to not mention the side effects of statins to patients? Based on what you presented earlier.
Well, again, a big difference between the U.S. and Canada is that we don't have as much influence of pharmacists. I wished we did, but so no, I haven't come across that. But I'm pretty cautious with my discussion of patients with side effects. As an AFib doctor, I feel like a psychologist, and so I watch my language pretty closely because I'm really confident that there's a nocebo effect from clinicians.
Moving on to the next question, a comment about a recent Canadian Medical Association journal article that talked about risk scores, and they actually seem to overestimate risk based on a cohort in Eastern Province in Canada, Ontario. Do you have any comment on risk calculators and the evidence that suggests that they overestimate risks and how that impacts the decision?
Yeah, I believe that they do. I can't quote from that paper, but I've read other papers that suggest that. And again, I would just fall back on the risk scores just put us in a sort of global area. And like that modeling study that I showed, when you count competing risks and when you count, you know, all the adverse effects that could come from statins, including, pill disutility, they would argue that you should be a higher risk to start these preventive therapies. I can't, I think it's a discussion with the patients and getting a feel for what they really want to do and how they handle the risk. And I mean, it's doable. Patients really can, they're like the tiebreakers for me. I really just get a feeling for them, what they want to do. And it often works out.
Thank you. I remember when I was seeing patients in a pharmacy practice, and some patients had commented, and one was my father, who said that when he took a pill, he felt sick. And other people that said when they took a pill, they felt like they were contributing to improving their health. So who knows, right? It really depends on the individual.
Exactly.
Okay. Okay, let's see. Are there trials of quality that compare the same investment of time, money, and resources into lifestyle interventions versus prescription drug therapy?
Not that I know of, because of course, those crucially important things don't have an advocacy group. And yes, I feel torn about talking about drugs because I'm an advocate of all of that, and I think that's crucially important, vitally important. And so no, I don't think we'll ever have RCT level evidence like we do for drugs.
Is there any evidence that patients with a family history of cardiac events are some of those who benefit the greatest taking ASA or statins for primary prevention?
Yeah, not that I mean, I can't cite you one specifically, but I can point you towards the work of the Boston Mass General folks who are looking at polygenic risk scores, and it's very controversial because these polygene risk scores are, the notion is that you can look at somebody's DNA, look at their SNPs, single nucleotide polymorphisms, and put together a gene risk score. And then in those patients who are high risk by their gene risk scores, posit that they're going to benefit more from primary preventive therapies. And there is some data on that. But that also is very controversial in terms of the methods and whatever. But I wonder that in 5 to 10 years, it won't just so be the family history, but it'll be our gene. I think there is there's probably going to be some signal in our genes about our risk. But right now, this is a hotly debated topic.
Okay, thank you. A few people are asking, what do you think about this risk score versus that risk score? And then, so I guess it may boil down to, what do you use? Do you have a preferred one?
I just use the ACEI risk score.
Okay. How do you approach your conversations with older adults that are high functioning to present the data of harms and benefits for statins?
Yeah, well, I just like we just basically on a piece of paper, we write down what the risk reduction is. We write down what the potential downsides are, and we go over these things, and I sort of draw almost like a seesaw, and then stop talking and see how they feel about it. And for me, I'm more often doing it for AFib and anticoagulation, but it does come up with statins in my patients with heart failure. So yeah, we just do that, and I would say each patient is a little different.
Okay, thank you. Would you deprescribe statins and beta blockers in an elderly patient who is frail and has cognitive decline, who is dependent on care for their activities of daily living? And
yes.
Of course, they would be secondary prevention.
Yes, I would. If you're in patients who have cognitive decline or patients who are needing care, look, none of those patients were enrolled in trials. And like I showed in the beta blocker trials, the beta blocker post-MI trials, I mean, these were done in 50 to 60-year-old people back in the 1990s. And so I think it's just crazy to try and apply, guideline-directed medical therapy and RCT level evidence to anybody who uses a walker, doesn't get out of the house, has cognitive decline. Not all bets are off for those patients, and I would just deprescribe in a heartbeat.
Okay. I'm laughing at this comment. If Stacy's around, your wife is a wise woman. People should eat food, not pills. So.
Yes, Aaron, I'll tell you that. I have to give her a lot of credit for my success, because she's like a secret weapon. Like, people think I'm smart, but really a lot of it, I'm just parroting what Stacy says.
Well, it's good of you to admit that. So would you use statins for hypertriglyceridemia?
Yes.
Okay. For no matter what condition, at what age do statins fail to achieve significant benefit?
Well, I don't think you can do that, because, like the previous question said, there are 90-year-old people who really just are amazing. And so I do really, those graphs from Daryl Francis's group just really stand in my head as there's just less, not only is there less average benefit, but there's less, the odds of getting a big gain is smaller for those groups of patients. And so I'm not enthusiastic about using preventive therapies in elderly. And another, this is just something I thought of, but I often tell patients with preventive therapies who are in their 80s or 90s, and because it's often hard to deprescribe because patients don't want to sometimes, but I'll often tell them that the point of these preventive therapies was to make them 80 or 90 years old. Now that they're there, then there's a greater chance of harm. And so sometimes that sticks with people.
Interesting.
I mean, think about it. If you have an 85-year-old person, the average age is 78. And so they're 7 years to the good. And I think our job is to make sure that they don't incur any harm from us.
Very true. Wise words. Okay, we have a bunch of questions that are similar, sort of been answered already, and we're well ahead of schedule. So just to warn you, we might end a little bit ahead of time.
Okay,
so just ask a couple more questions. Since reading the studies you mentioned, do you prescribe statins to folks who have heart failure with reduced ejection fraction for secondary prevention?
I do not. I am so struck by those. Data. And, I went back and looked, and it's in the GC trial, 40% had their cardiomyopathy from ischemic causes. And in the Corona trial, I think it was 60% of those patients had previous myocardial infarction. And so those are, to me, that's a classic case of competing causes of death. And the big thing with heart failure now is polypharmacy. Heart failure patients, you saw the recent studies on SGLT2 inhibitors. That's another drug that's come up. So now you're looking at 4 guideline-directed medicines to take. And if we have 2 randomized trials that show no benefit, then that's people they can only take so many pills. And so I think it's a great place to deprescribe. And especially in patients who have non-ischemic causes of heart failure, I think for sure I would deprescribe or not prescribe.
Okay. I said 2 questions. We'll make it 3, so there's 2 left. The top 2 questions are: do you think a vegan diet has any or some benefit in cardiovascular disease?
Oh my gosh. I'm afraid to even talk about this because it's almost political here. I don't know. The answer is I don't know. I've been to I've been to some of the seminars that Esselstyn puts on, and he has some incredible anecdotes of reversal of coronary disease. The Mediterranean diet has a RCT level, not a perfect RCT, it was revised, but they have level of evidence. I don't know. BC is a different place than Kentucky. Kentucky is, I think, the 48th most unhealthy state in the U.S. And so if I can just get my patients to stop drinking soft drinks and cut down on their carbohydrate intake and eat real food, I consider it a win. And I actually don't know what the cardiovascular best diet is. And I wonder if it's even knowable.
Okay. And the last question, if someone has genetically low LDL but a strong family history of cardiovascular disease, or they've had a catastrophic event themselves, what do you do? Is a statin a good idea, a bad idea?
Yeah, well, certainly if someone has had a vascular event, an atherosclerotic event, I really don't even care what their cholesterol is. I would just treat them with a statin therapy. To be honest, and then if someone had a low LDL and a high HDL, that's going to lower their cardiovascular risk and those risk scores, and it's going to maybe decrease the absolute benefit. But I have to say that and again, this is controversial. There'll be people who disagree, but I think the role of cholesterol testing is really, in a global way, I think of it, okay, you test somebody to make sure that they don't have a familial hypercholesterolemia pattern. And if they don't, then, you're looking at cardiovascular risk in general, or their primary prevention, secondary prevention. And so I see it as less important as the overall cardiovascular risk.
Okay, thank you for that. And the last question I have for you is, if the border opens up and we invite you and Stacy back here, would you please come?
I would. I am so grateful. I am so grateful to be involved with what you all are doing. And of course, any common sense American loves Canada. We're envious of Canada, and people want to move to Canada. We don't even care how cold it is. Yes. So thank you very much.
Okay. Well, we've got a room for you in our house here, so anytime you want to come and stay. And with that, John, I know on behalf of all the participants and all the faculty at the TI and the CPD group, thank you so much for a wonderful talk.
Okay, thanks so much. See ya.